MSH will form you more melanin and the patient will be dark. The patient will be bronze. Okay. And even you will see the Palmar creases. Either they will tell you the patient has generalized pigmentation, but mostly in your MRCP part 1, they are telling about, they are making it a little bit easier. They're obviously telling the creases, like prominent pigmented crease, Palmar crease. I will show you the picture. Okay. So when it is from the primary, when the boss is himself, this is happening from the adrenal gland itself. But boss is somewhere else. Boss is maybe the boss is with pituitary. The pituitary is boss. That is secondary. That time, this is white Addison. White Addison means normal Addison. I mean, there will be no pigmentation. Why? Because the problem here, the ACTH will be low. MSH will be low. I mean, they will not produce MHS more because there is no negative feedback from here, from adrenal gland. The boss himself is suffering. That's why he doesn't have the hormone. So he cannot produce the MSH, the melanin secreting hormonal, that hormone. So that will not cause the melanin. So in a shortcut, if it is primary Addison's, you will get a pigmented patient. If it is secondary Addison's, you will get normal. There will be no pigmentation. That is white Addison's. White, I'm telling to make you remember. This is not a bookish term. Okay, dear? This is not a bookish term. We are making fun in our with our friends that when it is like Western country people are more white. No, you people are here already because we are brown. I'm brown. So we are telling that this is Western Addison. Okay, so secondary, when boss is somewhere else, this is the Western Addison. They are okay with their no pigmentation, they're white Addison. Okay, dear? So remember like this. So let us see. Let us just have a very quick look. See the, oh, not this.
Hello.
Yes, doctor. You want to ask something?
What are you looking for?
Oh, there, I'm showing you the Addison's hyperpigmentation, the creases.
Okay.
Okay. So can you see the creases, the lines of the palm? It's so hyperpigmented, so blackish. Okay. So this is the pigmentation of your primary Addison's. Is it clear?
Yes, ma'am.
Okay.
Yes, ma'am.
Okay. So how in your question, how you will diagnose? First of all, in your question, now I'm summarizing. There can be pigmentation hints. This is for part 1, I'm telling. They will give you some investigation. They will give you some investigation. So they will tell maybe BP, you will find low, glucose, you will find low, sodium, you will find low, potassium, you will find high. So with that, it is definitely Addison's. So you diagnose the case. You diagnose the case from the clinical signs symptoms. If it is clear, I will go for the next step. Dear. Is it clear?
Clear, ma'am.
Yes.
Okay. Next important thing. You know, Addison's is why it is happening actually. Mostly there are some causes, right? There has to be some causes. So when there is like autoimmune condition, I mean, there is problem with the defense mechanism of the body. What defense mechanism of you and me, what it is doing? That whenever there is bacteria and virus is going inside us, they're fighting, right? So autoimmune diseases are what? Their own defense mechanism is attacking their own health. Okay, that time, the diseases which are happening, that is we are telling the autoimmune diseases. Addison's is a autoimmune disease. Whenever one Addison disease is in your question, please, your brain should be detective, your brain should be in a detective mode. You should be like Sherlock Holmes. Okay, why? The question from Addison's, if it is, you know, there is obviously mixed up of questions. Some question will be very easy, some question will be moderate, and some question there will be very, very difficult. So if you want to solve that moderate and difficult question, you need to understand this twist. Okay, whenever you see Addison's disease, you are thinking that from the scenario, it could be Addison's disease. Please, the first thing should be search for any other autoimmune disease in your question or not. They are correlating. They are correlating. If anybody has one autoimmune disease, they are highly suspicious to get another autoimmune diseases. So for you guys, for your whole MRCP journey from part 1 to PACES, I want you to remember this MOTA card. This is the MOTA card. I think I have people from Bangladesh. You know, the MOTA is in our language. What is that? Anyone from Bangladesh? What is MOTA?
Are you from Bangladesh?
Yes,
Oh,
I am. Yeah, fat. I'm from Bangladesh.
there is one girl from Bangladesh called Biti in UK.
Oh,
Very,
inshallah.
you
So many.
know her?
What's the name?
Biti. She said her Biti. I don't know if she's
I said
Biti.
Betty or something like that, woman.
Oh, better. Okay. Yeah, it's a local language actually. It's a local language. It's a girl in a like of a in a kind of village language. Okay. So MOTA card is BT. Okay, BT. Yeah, it's a name. Okay. It could be a name also. Yeah, you are right. Okay, I don't know her, dear. So MOTA card is the thing I want you to remember throughout your MRCP. Inshallah. I hope whoever you are here with me today, inshallah, within 3 years, 5 years, you will get the MRCP fully. So I want you to remember this MOTA card from the starting till your ending of MRCP journey. So what is MOTA card? What is MOTA card? MOTA, M for myasthenia gravis, O for ovarian failure, premature ovarian failure. Okay. T for thyroid. A for this, our Addison's, what I'm talking now. Okay. Card, C-A-R-D. So this C for celiac. A for anemia, the pernicious anemia, the pernicious one. Okay. R for RA. D for DM, diabetes mellitus type 1. This is my MOTA card. This is the, yes, this is standing for this one, dear. So this MOTA card, you will be very happy to find out when you can correlate the diseases with one another. If you can understand this, trust me, endocrine number will be high up in your exam. Trust me. And this is the thing where the mostly complicated questions are coming. So if you can really solve it, if you can be a very successful Sherlock Holmes, you will get a very high mark in endocrine. Okay. So like here, I will tell you, like here, Addison's. Now I'm talking with Addison's, right? I'm talking with Addison's. You see, I was telling you there is hypothyroid. Addison's can be with hypothyroid. There is a name of some polyglandular type of syndrome. APS, we are telling, autoimmune polyglandular symptoms. These are that I'm going later on, inshallah, that I will come later on, one by one. So whenever Addison's is there, the patient can have thyroid also, thyroid problem. Or maybe the patient is having Addison's, the same patient can have diabetes. Okay, so the thing you need to know that any of these diseases can present in the same body. It could be 2 diseases together, 3 diseases together. So autoimmune disease, whenever one is positive, there is high chance other can be positive, at least for your MRCP, because they love it. because this is the place where they can twist the questions. Okay. So I will ask you the motor card. Dividing it primary cause, secondary cause, some exogenous glucocorticoid therapy if you are giving from outside, something they are calling pseudo hypoaldosteronism. Okay, 1, 2, 3, 4. Let me give you clarifying it one by one. Pseudo hypoaldosteronism. This is showing like there is hypoaldosteronism because of aldosterone resistant actually, due to spironolactone. If you have done, I think August batch there with me, we have done nephrology. Can you tell me which type of renal tubular acidosis we are getting this aldosterone resistance?
Type 4.
Very
4.
good. This is our pseudo hypoaldosteronism. This is RTA4, and this is the only RTA with hypokalemia or hyperkalemia?
Hyperkalemia.
Hyperkalemia. Very good. See, this is our Addisonian. Potassium is high. So this pseudo hypoaldosteronism is actually the RTA4 where you are getting hyperkalemia. See, now we are synchronizing nephrology with endocrine. Number 1, finish. Okay. Now I'm going from down to up. Exogenous glucocorticoid therapy from outside, if they are giving, then yes, because of negative stimulation, it can go with Addison's. There is no question from here. Just to make you know. Okay. The main theme that you need to understand some primary causes and some secondary causes. Okay. Primary cause, as you know, if the adrenal gland itself is boss, this is the primary cause, if itself affected. If somebody else is boss outside of adrenal gland, that is the secondary cause. Okay. So outside of adrenal gland, it could be pituitary, could be the boss. Okay. So in case if there is like pituitary is boss, yes, maybe pituitary has some own problem that it cannot release the hormone. So it will affect the adrenal gland. They also cannot release. So pituitary gland, it could be with tumor, any kind of infiltration, maybe amyloidosis. So many things. It could be metastasis, whatever it is. Pituitary is sick. If pituitary is sick, so he cannot provide enough ACTH. So ultimately, the adrenal gland will also be sick. So here the boss is the pituitary gland. Some other drugs also, ACE inhibitor, heparin, you can get this type of hypoadrenalism. Do you have any question from there? Till now, I didn't get any question from these drug causes. Okay. Now come the important thing that I want you to remember, and you have questions mostly from these primary causes. You have question from these primary causes and from the pseudo hypoaldosteronism. Pseudo hypo because RTA4, okay, and this primary causes. This is important. Okay, now important things. This primary cause, how you will remember? Remember, it could be with infection. It could be with infection. So what type of infection? Maybe whenever, especially patient is immunocompromised patient, and you are thinking in that immunocompromised patient, there is Addison's, your diagnosis, your DD should be 2. It could be TB, or it could be HIV, or it could be HIV. So this 2 DD, whenever you know that the patient is immunocompromised and he's having Addison's, so if what could be the cause? It could be because of TB or because of HIV. Okay. TB can affect the adrenal gland, and also HIV patient, there is a syndrome that we are calling Irish syndrome. Important. When we will go to the infectious disease, you will come to know. And whoever already done infectious disease, you know. This is immunoreconstitution syndrome. What is this? In a short, I will tell you, we will repeat it again in our HIV. A HIV patient comes to you, AIDS patient, you start HERT. Now this is the new rule, right? Once it is diagnosed, the day it is diagnosed, actually, it should be start the HERT therapy immediately. Before, the protocol was different. Now the new guidelines, it is HIV, it is a HIV, you start HERT. Okay, it's AIDS, you start HERT. Okay. So whenever you start medication, HERT therapy, what happened? They are getting more O's. The patient was very good. He was controlled. He just, because of some small sign symptom, and because of a bad, maybe he had a very bad sexual life history. That's why he's diagnosed as having HIV with AIDS. Okay. So you start hurt and you make that patient worse. The patient will come back to you and he will shout to you, what have you done to me? I was good. I was good. You have given me something and you made me more sick. What is that patient is having? The patient is having immunoreconstitution syndrome. It is because there is hyper-responsive inflammatory response. Okay. In these cases, so after treatment, if there is this kind of response, there are some bugs and opportunistic bugs. I mean, virus and bacteria, they can attack that patient. Okay. So this, when they are having this kind of, they're getting worse after getting the medication, that is known as IRIS, immunoreconstitution syndrome. Okay, dear, IRS. Okay, so this is the IRS. So what happened? This HIV patient, you start hard and he got cytomegalovirus, and this cytomegalovirus is attacking the adrenal gland, causing adrenalitis. Ultimately, your AIDS patient comes to you with Addison's criteria. So how the scenario is coming in your question? Scenario is coming, patient is HIV diagnosed, now comes to you with nausea, vomiting. Okay. Now they did investigation result, they will give you all the Addisonian feature. They will give you sodium low.
You said before also rheumatoid arthritis can make Addison?
This immunoreconstitution syndrome you are telling?
Yes, you said that rheumatoid arthritis
No,
can make Addison.
No, not rheumatoid arthritis. Maybe my slip of tongue. Not rheumatoid.
Because you said the MAT code.
Motor card. Okay. No. This is, I'm telling that, like, that is different, dear. That is, I'm telling that these 8 diseases, any of them can be together. Any of them can be together. Okay, you got it? Like Addison's disease, somebody comes to Addison's, you need to ask him the question to rule out if he has motor card, any of them. You have to rule out, are you having any joint pain? No, doctor. That means he doesn't have any rheumatoid arthritis. Are you having are you a diabetic patient? You need to check the RBS if he's having diabetic type 1. Are you getting me? Are you getting me, dear? That if somebody is coming to you with Addison's, you need to find out if he has any of other disease from motor card. There is high chance that they can have together any other diseases. Is it clear now?
Okay,
yes,
okay.
Okay, dear. Okay. This is something else. This is, I'm telling what are the cause that adrenal gland is getting sick. Adrenal gland is getting sick, and that whenever adrenal gland is getting sick, GFR will not secrete ACD, there will be Addison disease. This is the causes. This is the causes. Okay. So why you need to know the causes, primary causes very clearly, because the scenarios are coming like this. HIV patient can have Addison's disease. If you don't know that, how you will diagnose? Okay. So HIV patient, maybe the scenario they will give you that HIV patient, they have started heart therapy. After that, he comes to you getting more sick. Investigation showing sodium low, potassium high, glucose is coming down. That means he has developed Addison's. He has developed Addison's. Finish these 2 causes. Another cause of infection. So we were with infection, right? We were with infection. One, I told you TB, another one HIV, another cause, it could be meningitis. The meningococcal infection, when it is spreaded, meningococcal infection where? Meningitis is where? It is affecting the where? Meninges of the brain and spinal cord, right? It is in the brain and your spinal cord. But when it is spreaded, septicemia through the blood, septicemia means what? The infection is now spreaded through the blood all over the body. So when from this brain and spinal cord, it is spreaded to your adrenal gland. It is causing hemorrhage, bleeding in the adrenal gland and causing this. This can also cause Addison's disease. See, and this, when this is starting from this meningococcal infection,